Okay, good morning. Good morning to one and all. This is okay. This is your wise doctor. We came to the part 4 of our class. I think yesterday we finished something up to dose response curve, right? We discussed dose response curve. Finished. We discussed dose response curve. Guys, actually I have to say something, right? Yesterday I did not discuss this formula, but today I will just discuss it. Just welcome to the class everyone. So we don't make any delay. We'll just get into the class, right? Now we'll just starting with this. Yesterday I should say this, but I forgot to say this. Maintenance dose calculation. What is the maintenance dose calculation? It is clearance into target plasma concentration, right? Guys, remember this formula. This is very much important. Why? Because in the INICET it's one of the favorite question. It is the favorite question of the examiners, right? Maintenance dose. How to calculate the maintenance dose? You will get the value of clearance, you will get the value of target plasma concentration, and the examiner will ask you to calculate the maintenance dose of a particular drug, right? So maintenance dose is equal to clearance into target plasma concentration. Now how can you calculate the loading dose? How can you calculate the loading dose? Loading dose is equal to volume of distribution into target plasma concentration. Doctors, please remember this two formula. You might get a chance. There are high chances of getting a problem regarding this formulas. You will get the examiner will give you the values of loading dose. They will give you the value of target plasma concentration, and they will ask you to calculate the volume of distribution. So you just remember these two formulas. Then it will be very much easy to clear all those MCQs. If you get even tougher also, you can easily clear those MCQs. And yesterday we will discuss something about competitive antagonism, and we also discussed about non-competitive antagonism, right? We discussed about competitive and we also discussed about non-competitive antagonism, but I forgot to tell you some points, some important points, right? What happens in competitive antagonism? How will the graph shift? What did we discuss yesterday? In competitive antagonism, what happens? The efficacy remains same. But what happened? That we increase the dose. That means the potency decreases. That means the efficacy remains same. But the potency, what happens to the potency? The potency decreases, and the graph shifts towards the right side. See, the efficacy remains the same, but the potency decreased. How can you tell the potency decreased? Because the graph is shifting towards the right side. Right side means the dose of the drug is being increased. The minimum dose that is required to produce its effect or action is being increased. So obviously the potency decreases. Why? Because potency is inversely proportional to the dose. If the dose increases, potency decreases. If the dose decreases, potency obviously increases. Potency is inversely proportional to dose. That is regarding competitive antagonism. But if you come to non-competitive antagonism, what happens in non-competitive antagonism? What we discuss? The potency remains the same, but the efficacy decreases, right? See my drawing is very much ugly, but I will draw clearly right now, right? So we are discussing about non-competitive antagonism, right? What happens in non-competitive antagonism, right? The efficacy decreases, remember, but the potency remains the same. The efficacy decreases, but the potency remains the same. Potency remains same, but efficacy decreases, right? Potency remains the same, but the efficacy decreases. Guys, remember these statements. These are very much important, pure concepts, right? Yesterday in the previous class I explained everything, but if you have any doubt, please check once again, right? Now in competitive antagonism, in competitive antagonism, what we should discuss, what we should see some other points like in competitive antagonism. See, the so-called there are two factors, Vmax, maximum velocity, Vmax, with which the reaction goes on, or maximum action that is produced. Just think Vmax like efficacy. You just think like that, then everything will be transparent. But in the next classes I will discuss in detail what is meant by that, right? And what is meant by Km? Km, you please think like potency. You just think Km as potency. You just imagine Km as potency, the value of potency, and you just imagine Vmax as efficacy. Now what happens in competitive antagonism? Efficacy remains same. That means Vmax remains same. But what happens to the potency? Potency decreases. So Km decreases. What happens to Vmax? Vmax remains same. Why? Because efficacy in competitive antagonism remains same. But if you come to non-competitive antagonism, what happens to Vmax? What is Vmax? Previously we explained efficacy decreases. That means Vmax decreases. What happens to Km? Km remains same, because potency remains same in non-competitive antagonism. So Vmax, just think like efficacy, and potency take it as Km values. You just remember these two things. Then if any question arises, for example, what happens to Vmax in competitive antagonism? It remains same. What happens to Km value in case of non-competitive antagonism? It remains same, right? So Vmax is efficacy and Km is potency. Just remember these two things. That is very much important. Now if you ask me what is Vmax? Vmax means maximum velocity with which the reaction takes place. The reaction occurs. This is something which resembles to efficacy. You just remember it like efficacy. Now what is Km? Dose at which maximum response is seen. That is Km. So it resembles something to potency. Now I think you got the concept, right? Okay, next we'll go to the next topic, that is receptors. We'll just make it fast. Receptors, what are different types of receptors? First one is ligand gated receptors, and second one is nuclear. Third one is enzymatic. Fourth one is G protein coupled receptors. GPCR, G protein coupled receptors. Okay, G protein coupled receptors, right? Now if you ask me what are the examples are very important. You will get a question, all of the following are ligand gated except, all of the following are nuclear except, all of the following are enzymatic except, all of the following are G protein coupled receptor except. So you will get a question like all of the following are so and so except, right? Just remember those things. Okay, now if you come to ligand gated, the examples are GABA receptors are ligand gated, and glutamate receptors are ligand gated. Now if you ask me another one, nicotinic receptors are ligand gated. Then 5-hydroxytryptamine, 5-HT means hydroxytryptamine. if you ask me what is the type, right? If you ask me, it is NMDA, N-methyl D-aspartate, NMDA. And if you ask me in nicotinic, what are the types of receptor? It is NN and another one is NM in muscular region and in its other sorts of where the cholinergic transmission occurs, right? Cholinergic transmission occurs. It's two types of receptors, NN and NM. If you ask me GABA, it's NMDA because N-methyl D-aspartate type of receptor, right? Glutamate and 5-HT3 ligand gated receptors. Now if you come to the examples of nuclear receptors examples are vitamin D receptor, then mineralocorticoids, then glucocorticoids. So you can just simply remember it like so-called hormones released by adrenal gland, that is mineralocorticoids, glucocorticoids, sex corticoids. Mineralocorticoids and glucocorticoids are nuclear receptors. But if you ask me, sorry, I think we made a mistake. Wait. I will correct it. It's not nuclear, it's cytoplasmic. It's cytoplasm, right? They are located in the cytoplasm. But if you ask me, wait, I will just refresh it. Right? So first one is ligand gated. Ligand gated receptors. Examples, what are those? GABA. Next, glutamate. Next, nicotinic. Next, what is the final one? GABA, glutamate, nicotinic and 5-HT3, 5-hydroxytryptamine. Now second one, if you ask me, these are actually two types. One are nuclear receptors and another one are cytoplasmic receptors. There are actually two types of receptors which are located in the nucleus and which are located in the cytoplasm. If you ask me which are located in the nucleus, thyroid receptors, then very important, androgen receptors are nuclear receptors. All androgen receptors, estrogen, progesterone, testosterone. Guys, some of the doctors, they just raised a question like, sir, in this book it is given like that, in this book it is given like this, testosterone is a cytoplasmic receptor, estrogen is C. I can show you in Goodman and Gilman, all androgen receptors are simply nuclear receptors. Estrogen, progesterone, testosterone, all are nuclear receptors. There is no doubt in it. And if you ask me examples of cytoplasmic receptors, it is vitamin D, then comes mineralocorticoid receptors and glucocorticoid receptors. All these are cytoplasmic receptors. Now third one, enzymatic receptors. What are the types of enzymatic receptors? So what type of enzymatic receptor? Tyrosine kinase receptors. So there are types in this enzymatic receptor. There is a tyrosine kinase receptors. In tyrosine kinase receptors, what are the examples? EGFR, epithelial growth factor receptor, VEGFR, vascular endothelial growth factor receptor. Next, HER2. Can you tell me where in a body HER2 receptors are present? Breast. In breast carcinoma, these HER2 receptors are very much favorable if they are positive. If they come with a positive state, then obviously it is very much favorable for the treatment. Remember HER2 receptors. What are another types of tyrosine kinase receptors? What are the another example for tyrosine kinase receptors? Very important, insulin receptors. Doctors, please remember, insulin is a tyrosine kinase type of receptors, which is an enzymatic receptor. Insulin receptors are tyrosine kinase receptors. Now another example is insulin growth factor, right? Now another one is toll like receptors. Toll like